Good morning, Croc Nation, or as we say, citizens reunited to overcome cancer. Today is February 15th, 2026. It's Valentine's Day weekend. And before we begin today's, we're going to call it Replay Rewind episode, we want to take a brief moment to address our listeners directly. What was originally intended to be a two-part conversation is now being presented in its entirety as one complete episode. See, after careful consideration, we felt that dividing the discussion would take away from the way the story unfolded and the impact it carried. This conversation deserves to be heard in full. We also want to sincerely apologize for any audio issues or technical mishaps that may have occurred during last week's release. Since then, we have carefully reshaped and reformatted the episode to ensure a clearer, more seamless listening experience. We appreciate your patience and your continued support. We hope you received this conversation as it is meant to be heard. And as always, we'll be back next week with an entirely new episode. Are you ready for the Croc Podcast? Citizens Reunited to Overcome Cancer starts right now.
Welcome to Citizens Reunited to Overcome Cancer, a show to make your survivorship an easier journey by providing information and advocating for you. A show to help practitioners and their level of performance. This is the Croc Podcast. Here is your host, Dr. E. And alongside him to share some hope and inspiration from the Have Faith, Let It Begin podcast, co-host Angel Santana.
Hello, everyone, and welcome to another episode of the Croc Podcast. My name is Dr. Eanelli, and I am overwhelmed with gratitude and emotion to introduce the first of a two-part module on mental health and behavioral health for the cancer survivor. To start, I am unbelievably grateful and humbled to have with us Dr. Cara Bohan, a true trailblazer and innovator on this subject. Cara, it comes to us from such a wonderful background, starting at the University of Vanderbilt and then on to get her doctorate and her master's at the University of Oregon. She's a clinical psychologist and researcher with experience scaling delivery of evidence-based mental health treatments to meet the huge needs of patients across the United States. She is the co-founder and chief clinical officer of Protocol Behavioral Health, who focus on creating access to expert emotional and behavioral health support for patients with a cancer diagnosis. Before that, Cara was at Stanford University as an associate professor, working on different things that she'll discuss with us. She is a true big league, powerful human being who is going to change the game for our cancer survivors. I can't even count the amount of articles and peer-reviewed research topics she has done and she has produced, and it gives me great honor and privilege to introduce you, Cara, to the Croc Podcast Nation.
Wow, I'm kind of speechless. I don't know. I hope I live up to that introduction.
You absolutely will. Your work actually stands by itself. And I also want to introduce my two co-hosts today, which is something unusual. Besides Angel Santana, my usual guy in the sidecar of my little motorcycle traveling through life, is my delightful and intelligent wife, Dr. Denise Serrano Eanelli, who's going to keep the two of us on track to make sure we ask all the right questions to Cara. Cara, to start, I want to just tell you a little story that happened to me in the clinic that sort of will be a nice introduction to really, we're naming the episode Closing the Gap, but it's really not a gap. It's a huge schism. It's as wide as the Grand Canyon as far as why our cancer survivors don't have access to great mental health resources. When I was preparing for the podcast, of course, excited, enthusiastic, incredibly out of my mind, excited to have you and introduce you and to address these issues. I also felt a sense of sadness. I felt very distressed about the amount of no exposure and very low priority our survivors get on their mental health, especially considering what a life-changing and stressful journey cancer can be. And I think this feeling of hopelessness was amalgamated in my mind this week with the story of Kelly. So Kelly is a brilliant, ebullient gentleman that just finished his active treatments for laryngeal cancer. Anyone who works in cancer knows that cancer of the larynx is very scary because not only is it the seed of how we communicate and how we relate to other people, but it's also our airway. It's our seed to life. It's what gives us breath. As the days turned into weeks of his treatment, and as the weeks turned into months, I saw a huge change in his entire demeanor and his entire countenance. And he expressed very clear signs of depression, which stemmed from his diagnosis, of course, the threat of him losing his voice in the entire voice box, as well as the pain and suffering from the treatment. So he had difficulty swallowing and he couldn't taste, and his secretions became so thick that he really felt like he was drowning and choking every time he would try to lay down. And you add to that a significant and real impact of a fiscal crisis that he was going through to the point of being close to having to move into his car. What happened was he was out of gas. He was at his George Bailey, It's a Wonderful Life moment, standing on that bridge, trying to make a decision whether or not he was going to jump off that bridge. And in the movie, as we know, for anyone who's seen that movie, when Jimmy Stewart is about to jump, his guardian angel Clarence comes down and jumps into the water, freezing water with him, and then he has to end up saving Clarence, and the rest is history. And I wanted to say that I wanted Kelly to have that Clarence moment, that bridge moment, that George Bailey, Jimmy Stewart moment, and something different happened. So, of course, the nurses and myself, we called for, mental health access. We brought him to the access center, to the crisis center, because his life was truly in danger. And he did express a desire to end his life. And I wish that the ending that Kelly had was the same as George Bailey, but it was not. So Kelly is still with us, thank God, but his access to care, the depth of the care that he received, and the quality of the care that he received was not stellar. And every day I pray that Kelly stays with us, which got me to thinking, in that same week that Kelly was in crisis and threatened to end his life, I also saw 4 other cases of life-threatening oncologic emergencies. I saw a patient with a spinal cord compression that required immediate attention. I saw a young patient with acute leukemia. I saw a patient whose tumor was pressing on all the big vessels of his chest. And I saw someone whose brain was swelling. And in each of these cases, an expert medical care was necessary. Otherwise, all 4 of these patients would have been dead within 24 hours. And I went deeper to find out in my mind to try to reconcile what the difference was between Kelly, whose life was in danger, and these other 4 patients. And the only thing that I could think of was that his disease was not visible, whereas the other diseases were. And there was no blood test that can tell us that Kelly was in danger, and there was no scan that could tell us that. And there was nothing on a physical examination with a stethoscope that could tell us that. But at the end of the day, I felt that there was an inequity. There was a discrepancy in care. And Cara, the reason why we're so blessed to have you is because your life's work accumulating now in protocol addresses these types of issues. So I guess besides welcoming you, the first question I'd like to ask you is your journey and how you got to protocol and how you got to value a situation like Kelly's and why that shouldn't happen and why in the future, hopefully, it will not happen anymore.
Yeah, it's an incredible story, and I love that you linked the story of Kelly to the other medical emergencies that were just as important and just as vital. It's interesting you asked about my life work and how I got to here. I actually started when I was in grad school getting my PhD, and then the early part of my more academic research career was actually in trying to find brain scans that could tell us about mental health conditions and seeing if we could do a scan. I did a bunch of functional brain imaging in my career where I was thinking, is there a way that we could use MRI and see the things? We know that these are brain-based functional disturbances that go on for folks when they're struggling with their mental health. So where in the brain can we potentially find what's going on? And our challenge is there's so many, the brain is so complex functionally that being able to get a definitive scan to determine any of this is still, maybe we'll get there, but I'm just not convinced that it'll happen soon enough. And I wasn't willing to wait anymore. And so thought I need to do something different. And instead of thinking about what scans we might be able to get there, let's just keep asking questions about how people are feeling. And let's just make sure that we don't have people fall through the cracks because we didn't ask them the right thing about how they were feeling, or we didn't think to ask them because we thought maybe they were fine because maybe they're on, talk about survivorship. Well, maybe we didn't know asking because we assumed, hey, you're out of acute treatment and you've got no evidence of disease. Aren't things better? And so we just stopped asking, right? So instead of spending my career continuing to hunt for the right brain scan or something, I thought, let's shift this a little bit and let's think about making sure we're asking the right questions and then making sure we have the right follow-up when you do ask. And so that's a little bit about where I landed in this space in particular, was really actually personal. I started off, I'm a psychologist, focused on research initially, thinking about how could we make treatments for mental health conditions better? How could we get better outcomes? And then I thought, what does it matter if our treatments work if no one can even access them? If no one gets referred to them, no one gets identified and is able to see them. When I was at Stanford, our clinic had a 9-month wait list for some of our specialty clinics. And I thought, what does it matter what we're doing? We need to create access to care and improve that. And so really shifted my focus about 5 years ago and said, forget the improving treatments. I mean, I think we should improve treatments too, but let's also improve access and really focus in there. A number of years ago, I had a couple of family members get diagnosed with cancer, and just was really struck by the access to care gaps there, specifically for mental health. I'll, share one example of my mother-in-law who has stage 4 colon cancer, and she was going to start chemo pretty quickly after diagnosis. She had surgery actually initially, and then was going to start chemo pretty shortly after that. And there was a lot of distress, understandably. It's how, someone I was talking to was like, how can you get diagnosed with cancer and not feel distress? I mean, it kind of goes hand in hand, right? And so, of course she was distressed. Who wouldn't be? Trouble sleeping, anxiety around what's to come, what is chemo going to be like? What are the side effects going to feel like? A lot of anxiety, spread of disease, things like that. And so I said, I'm a psychologist. I said, let's get you connected to someone who can help you. The oncologist absolutely agreed. I mean, every oncologist knows this. Yes, absolutely. Let's get you connected. Put in a referral. And then it was going to be 5-6 months before she could be seen. And I just was like, but her chemo starts next week. It's a 3-month regimen. She's going to be done with chemo before she even gets a first appointment. And so that's really flagged to me, just that there's this, I mean, you said it's not a gap. I keep saying, but you're right. It's not a gap. It's way bigger than a gap. And I started diving in and where could we close this? How could we do something different? We started protocol behavioral health about a year ago. And really, we named ourselves protocol actually because we feel like behavioral health and mental health support should just be part of the treatment protocol. It should just be, this is your chemo, here's your surgery, here's your radiation, here's your mental health support, just part of the protocol when you're getting your treatment regimen. Yeah, that's a little bit of
It's a beautiful intro as far as how you got to this place and how protocol is trying to change the model. I think the word that keeps coming across in my mind and when I read your website is the word integration. And you and I, when we were preparing for the podcast, we both agreed that pediatric oncology has the model correct. And it's an almost all inclusive. It's like going when Angel and his family goes to Mexico, they go to a all inclusive resort where he can get his drinks, he could get his fajitas, he can get everything, he can get his mariachi band, and he could get his ocean pina colada all in the same place. And I'm afraid that that's not the case with adults. And can you comment on that?
Yeah. My nephew is a leukemia survivor, pediatric leukemia. He's 7 now, but was diagnosed at 3. And yeah, they have family support groups that are part of treatment. They've got child life, art therapy, play-based things that go in every time you've got an appointment. So many nonprofit organizations, honestly, that focus on supporting pediatric cancer and opportunities. The Make-A-Wish Foundation, there's a lot of kids getting great, care and support. Families get support. There's opportunities for siblings to have things done for them and support because we know that it impacts the entire family and it's just really embedded in their care. And there's just this gap that doesn't happen for adults. Adults go in for care and it's like as if because you're an adult, you should be able to handle it.
And with protocol, I mean, I think that the organizations that you're partnering with, you are as important to that process as me as a radiation oncologist or my colleagues who are surgical or medical oncologists, our nurse practitioners, our advanced care practitioners, our physical therapists, speech and swallowing, our dentists, our nutritionists. I mean, it's almost as if you are basically reinventing what is so lacking, and I still can't explain why we let as a specialty let that go for so long.
It's interesting. Just this month, the National Comprehensive Cancer Network, NCCN, which has put out guidelines for cancer care for the last 20 years, just made an update to their distress management guidelines. And so for almost 20 years, they've had guidelines for distress management in cancer care. And that's really what prompted a lot of oncology clinics to start screening for distress. They developed the distress thermometer. And so clinics would use the distress thermometer or they would use the PHQ-9, which is a depression screener, and started thinking, okay, we need to be integrating this into care. And those guidelines have been around in cancer for, again, almost 20 years. But what happened was we were screening, saying, hey, what is stress? What is your depression? And then it was really up to the clinics to figure out what happened next. Again, the NCCN guidelines also talk about what they suggest to come next, but it often results in referrals out somewhere. And then it's up to the other side of that referral what happens from there. And so oncologists are left a little stuck where, if the referral source, if they've got a really strong referral source where they don't have a wait list and they've got expert care and things, then that could go great. It's just that reality is not very common. And so most of the time that referral goes out and there's a couple of things that happen. One is that the wait list is really long. Or 2, maybe the list is not very long, but the likelihood of them getting someone on the other side who actually understands cancer is probably really low if it's a place that's maybe a generic mental health, generic behavioral health referral source. And what happens when they end up in there is that people don't really understand the realities And so when you think about some of the techniques that we have for depression, for example, one of the most evidence-based treatments for depression is cognitive behavioral therapy. And one of the things about CBT for short is think about how to change the way you think in order to change how you feel. And so a lot of times we have negative thoughts and they drive our depressed feelings. And if we can just change those thoughts, let's say I'm going out for lunch with a friend and the friend no-shows and doesn't come, and I'm left at the restaurant with nobody sitting there with me. And my natural instinct is to say, are they mad at me? Do they not want to be with me? Whatever. That's a negative thought that might make me feel bad. But I could reframe that same situation and say, maybe they got stuck in traffic. Maybe they weren't able to text me because they lost their phone, or maybe they ran out of battery, or maybe there's just all these things that could possibly explain it that don't have to result in a negative feeling. Let's just reframe that thought. And then that's going to change how we feel. That's a very common treatment approach for depression. But now fill in cancer. And your negative thought is, I don't know what the next 6 months of my life is going to be like because I'm waiting on the scan results to determine what the next round of treatment is going to look like. And so I don't know if I can, go to a friend's wedding in Washington because I don't know if I'm going to be in treatment or not. And how do I reframe that thought when that is true? That's the reality, right? So when we're working with patients with cancer who also have depression, we have to adjust our treatment approach. You have to understand cancer. You've got to understand the treatment. And so a lot of times when patients are getting referred out to a general behavioral health or mental health clinic, they may not get that expertise that they really would benefit from. And they may end up matched with someone who doesn't understand their reality and is not going to be as effective.
Absolutely. As a matter of fact, from my perspective, from our clinic, I'm able to see things from my perch. And a couple of things you mentioned that I'll comment toward. Number one, the metrics. So, these indices, these questionnaires and things, our nursing staff is superb, but they only have a certain amount of time. And I see them rushing through these questionnaires, and I see that the body language, and I see that it's just another checklist, just checking it off to say it's done. And then the patients are going to be very reticent to share their true feelings when they feel that they're just basically being asked to give a number from 1 to 10 on how sad they feel. So that's one of the problems. The other thing is exactly as you said. I view these, non-specialized mental health professionals as having a very MASH type approach to just kind of putting a Band-Aid and getting these patients out of their access center as quickly as possible without any adequate support, follow-up, intervention, or anything. Even someone to the degree of Kelly, who was a potential suicide risk, it was like in and out of the access center in an hour, back home, with access to every dangerous weapon to off himself. And I think that's broken. That's a broken system. And thank God for protocol with your specialized care and your realization that the system is broken. Whereas your family member would get a really good, mental health professional 3 months after treatment is over. That really doesn't help much. So I really appreciate those comments a lot. And I wanted to ask you, kind of segue, that we talked a little bit about the pediatric model. We talked a little bit about the indices. But do you foresee, you know, uh, an ability for your model to grow and to basically spawn throughout not only our country, but throughout the world, to get this integrative mental health resource as part of the plan from the start for our survivors?
Yeah. So I realized I started to share this and then didn't close the loop, but the NCCN the latest iteration of the distress management guidelines now specifically recommend including collaborative care into cancer care. So it's not just screening, but it's also recommending that the follow-up for screening is actually collaborative care. So collaborative care is the model that protocol operates under, where we are partnering with oncology clinics to really become or augment. So some clinics do have behavioral health support in-house. It generally doesn't have the best capacity. It's hard to scale the numbers for all the patients who could really benefit from it. So we partner with clinics to become or augment the behavioral health and mental health support. And the idea there is to really create a seamless experience so that let me just walk through an ideal patient flow is new patient diagnosis. In that initial visit, a screening for depression and anxiety would kind of be part of that package. Now, notice I also add anxiety. It's not common to have anxiety as part of your typical screening at a cancer clinic to date. And yet anxiety is incredibly common for a lot of our patients because they're anxious about the things that are to come down for them in terms of what their results and prognosis might be, what the treatment's going to be like, et cetera. And yet we're still just measuring distress or depression. But so my ideal is you assess depression, you assess anxiety, as part of the education of a new patient in terms of what treatment looks like. Okay, you're going to start chemo, or you're going to start radiation, or you're going to start here, and here's what that treatment looks like. Normalizing and helping them understand that distress and anxiety is absolutely a regular response to this. And so therefore, part of the treatment, we also have a behavioral health team who can help you with support throughout. And so we'll schedule a check-in with someone from our team. And then we'll have that check-in with someone from our team, and we'll see if it makes sense for someone to have ongoing touch points with us. And what that might look like is that for someone who, kind of generally has strong emotion regulation and is kind of able to manage things themselves, it might not be very high touch for us. It might be just kind of some check-ins here and there, make sure things are going okay. And then, I don't want to ever overburden someone with, you've got enough appointments on your schedule when you're going through treatment. I don't want to overburden anyone, but we want to be sure that we're capturing everyone who might need more support and who might benefit. And so then someone who, like Kelly's a great example, might have some extra support. That might look like not even a regular therapy session on a weekly basis, but it might be, let me call you tomorrow and just check in and see how you're doing. And let me call you the next day and let's just check in and see how you're doing. And you might do that a little bit just as you assess safety and risk, right? We want to be sure that in this moment, while you're having all of these feelings about wanting to hurt yourself or harm yourself, I want to check in with you as frequently as possible, even if it's just a 5-minute phone call, until I feel like you're safe. And then we'll figure out, how do we build a sense of a life worth living in the context of your cancer diagnosis, or in the context of survivorship. And then all the way through the cancer treatment journey, all the way through to survivorship, if that's the end prognosis. That's another point where people often fall through the cracks because everyone's like, woohoo, you're done and you're fine. And let's keep it going. Let's make sure we've got some check-ins, because everyone might think it's okay, but now you feel like you're not getting the support in your life and whatever. But have that just be integrated into your care so that we know. And the thing about integration is that it means that our team also knows when prognosis changes. If you've got someone doing therapy from this clinic location over here, and then you've got your oncology team over here, suddenly your prognosis changes. A new scan happened and you went from, stage 2 or 3 to stage 4. You went from, something where we thought maybe it was curative, but now it's not. And now, something changed over here, and we won't hear about it over here until you tell us, the patient tells us, right? Integration means we're ready for it. We know. And so the next time that we see, heck, we could even pick up the phone and do it proactive to say, hey, I just wanted to check in. I heard about the prognosis shift, and I just wanted to check in and see care you're doing, right? We can be so proactive and integrated because we are together with the practice.
Yeah, beautiful. I mean, bringing in Kelly's example is perfect. And to your point, I think the reason why Kelly is still with us is directly associated with the caring of our nurses. The nurses, without even having any background in mental health, did exactly what you said. They tried to fill in that gap we're talking about, by calling him every day, by having him come in for us to, clean his wound and get his secretions under control. And I think a lot of times our survivors realize that there's no magic wand that's going to make their depression go away or their anxiety going away. Sometimes it's just these small acts of caring, these small acts of just reaching out to them and letting them know that you're there for them is what keeps them, in the game. And I wanted to ask you exactly that. Maybe a couple of questions that I had from the board about how we as non-mental health care providers can approach our patients and sort of, until a protocol comes into our system, how we can maybe help bridge that gap. And I guess the first question was, how does a friend or caregiver actually lend the support that our survivors need during their period of diagnosis through treatment and then thereafter?
Yeah. This one is an interesting question because there's so much variation in terms of how people like to be supported. Some people want to talk about their feelings, in which case the best thing you could do as a caregiver or a loved one or even a provider is like, ask how they're doing, give them the space to talk about it. Also give them the space for it to be bad. I have, I've had experiences where people will say, oh, how's your mother-in-law doing? She's sick right now. And, I say, well, not that great. And it's like, I didn't really want that answer. I wanted the good answer, but like create a safe space for the genuine answer of not great. It's not going great. And be able to be that safe place for someone. If you say, hey, how are you doing? And someone says not great, like lean in. That body language matters, right? Lean in and say, tell me about it. I'm listening. I'm here. Because a lot of times there's like that superficial caring that happens, unfortunately, in our world. And so showing that you're genuine, I think, is really meaningful. And also there are people who won't be ready to talk about their feelings or don't want to say it out loud. And I think being respectful of that too, but I think still asking can, again, just send a signal that like you care, but you're also not pushy. I'm okay if you want to say, I don't really want to talk about it. And that's okay too. People respond differently in different ways. And so I think just making sure that people know you're genuinely there. The other thing that I'll say on that is also sending the message that they're not a burden, that it's not too much. They'll never be too much. I think that's another thing with like, especially, we have patients at protocol who have multiple cancers, multiple diagnoses, and feel like at some point, am I too much for you? Is this just too heavy for you to deal with? And so sending that message that nothing's too heavy, like you can share anything. And if they're ready to, they will. And if not, they know that you're there.
That pressure you mentioned, Cara, the pressure of them feeling like a burden because their family is now, holding them up and all that type of thing. I also noticed that there's a guilt that the patients have, in the sense that there is fatigue from the caretakers, and they want the patient to go back to their normal state because that's good for everybody. It's business as usual, and it's not possible. And there's that added pressure that the caretakers put on to the survivor. How do you integrate the management of maybe even a dysfunctional, maybe not even a dysfunctional, maybe just a normal, but you know, stressed dyad between the survivor and their families?
It's really hard. And I will say, I want to develop, so this is a future state for us, but I want to develop richer and more substantial caregiver support options, because I do think that there is a challenge from the caregiver perspective that is like, this is really hard. This is really hard for me. And I don't want to complain about it in front of my loved one. I don't want that to make them feel worse, but I also am struggling because this is a lot. I'm struggling because the schedule is chaotic to be able to help get my loved one to all these appointments. And I'm also scared for them, or I'm also like, and I also, don't know what's going on. And, and then you move into survivorship, where I think a lot of people are like, woo, we're done. Let's be done. And because you're exhausted. And so that's where I would love to develop more caregiver supports. And so in the absence of some structured caregiver supports, I think it's really important for caregivers to find their own supports outside of their loved one with cancer, to figure out who can you vent to about how hard it is, who can you get support from to say that this is hard, so that you can be strong and keep going and keep up the support that your loved one with cancer needs. I do think it's a real worry, and it does happen where caregivers and loved ones get worn out and just kind of say, okay, we're done. And it's heartbreaking. It can be really devastating to the extent that we help provide support for caregivers. It's vital to keep that support going.
I wanted to say, for the caretakers and the caregivers, how I'm going to combine two of the board's questions into one and ask, when the patient, the survivor, starts circling and starting to deteriorate mentally, and the depression signs come up, what are the right and wrong things to say, and how do we physically have contact? Do we hug them? Do we give them space? Like, how do we address and how do we dive into trying to help the patient as they're starting to circle around that sea of despair?
Yeah, I think I'll answer the physical touch piece first. And I would say there's, again, a wide variation in how people want to be touched or how they respond to touch. There's also a complicating factor in cancer and physical health, where there could also be a pain, like actual pain going on. And so you want to be really aware of what's going on in someone's body. And so definitely like asking what would be helpful. And I think it's okay to say, my urge is to give you a hug right now to show how much I care. Would that feel good to you? Would that feel supportive to you? Because you don't know what might be the case for them if they're in physical pain. There's also history of trauma is really real for a number of, the population at large, which means including our population of folks with cancer. And so, there's a lot of, just in the general population, reasons that people may not want to have that physical touch. And so just being able to know what's going on for them. But even in people who may normally really want hugs, if there's physical stuff going on for them, this might not be the right time for them. I know a lot of folks who have had either cancers that have affected their facial structure, or if they've had surgeries that have visible scarring, there might be, again, feeling like, I don't want you to be too close to me because I'm concerned about how I look, or things like that. And so always just wanting to ask a lot of questions. At the same time, I also feel like there's times when you're feeling, especially if you're feeling really distressed and depressed, that someone saying, how can I help, can feel like it's too much. Like, I can't even think of all the things that could help me, because I'm feeling so down in the dumps right now that it seems like there's nothing. So my answer is going to be, nothing is going to help. Nothing that you could do would help. And so if you ask me, how can I help? I don't have an answer for you. And so that's where I think taking what you know about your loved one, what you know about the person pre-cancer, or under other different circumstances, I think can be helpful to make those suggestions. If you know that someone is a really social person, then saying, hey, what if we scheduled some time for some people to come over and see you? How would that feel to you? Would that be nice for you? And then you might schedule a visit with someone who they normally really love being with. If they're maybe a more like introverted person, then, is there something we can do to distract you? What if we just sat and watched movies together on Netflix and hung out? And what if we just did, trying to resort back to what you know about them, and then make those suggestions, because in the heat of the moment, they might just draw a blank and feel like nothing's going to help. I don't know if that was
No,
Yeah.
beautiful. Very, very perfect. And I was going to say, I'm going to give you my perspective, and I think you would agree. One of the things that's really important to me is that when a survivor walks into a room, whether they have stage 0 ductal carcinoma in situ or papillary thyroid cancer, both of which should be fairly easy to manage, or prostate cancer, whatever, early prostate cancer. And then you have your patients that are stage 4, maybe close to hospice and that type of thing. I think it's important for all of us to treat our survivors equally, in the sense that a person with stage 0 breast cancer still is going through a trauma. And you don't have to be on hospice, to receive that empathy from your caregivers and your caretakers. I was wondering if you could comment on that.
I think it's 100% right. And I think it's also something that exacerbates the challenge of cancer survivors whose cancer wasn't as visible or as prolonged with acute treatment, or, those kinds of things where maybe very few people in their life even know that they had cancer or have cancer. And they can feel very invisible. And so I think, reaching out when you do know and making sure that you're still checking in. I think what people forget who have never had cancer or had loved ones with cancer is that once you have a diagnosis, you're always worried about recurrence. And obviously you're worried about recurrence in the first 5 years, especially, but you're worried about recurrence forever. And it fundamentally changes your feeling about your potential future lifespan and health status. And it's fundamentally shifted. And so I think just having that recognition when people in your life, no matter what their diagnosis was, that's true for them.
Yeah, no question about it. And to add on to that question, do you guys have a special model in protocol with patients that are palliative care patients or hospice patients?
So so this is a little bit, let's get into the technicality of like how we bill for our services, which is that we bill alongside the oncologist, which is why we offer our services as integrated services with an oncologist. We bill as there's like these special team-based billing codes that get billed under the oncologist. For that reason, there's some limitations into how we can continue our services. So if someone is no longer seeing their oncologist that we're partnered with, then we would also be ending our services with them, because it's fundamentally kind of comprehensive with their oncologist. Same thing if they were to transfer to a different oncologist, we are kind of embedded with their oncologist themselves. When someone shifts to hospice, that is also kind of a shift in their care. And so that's another thing where we would like transition. We would work really hard to transition care, but we won't provide care at the same time, just because of that transition of care piece where they've kind of moved their care, if that makes sense. But palliative care we overlap with for sure, where we, if someone is getting palliative care, especially if it's really focused on pain management and things like that, our services can be really complementary, actually, especially if it's more of the palliative care is more medically focused on like pain management and things like that. We have some really great like augmentative resources on like relaxation and breathing, which can be incredibly helpful through pain management. through fatigue. We've got some strategies around fatigue management and how to sort of selectively preserve your energy for the things that really bring meaning to you and that you really value in life. So like if something is like not really bringing you joy in life, then you reduce the amount of energy you're spending there, and then increase your energy spent somewhere else in a way that brings you pleasure or joy. And that way, in a fatigued state, you have a limited amount of energy. Let's make sure you're using it in a way that makes you feel good.
Yeah, I think that makes a whole lot of sense. And I was going to say, as we go into the stretch here, what I'd like to do is I'd like to give you some space, and would like you to imagine that right now you're touching the lives of survivors, mostly in the Hudson Valley. You're coming from the West Coast or whatever, but we also have survivors that listen to the podcast from across the globe. And what I love about your life's work and what I really admire about you is the fact that you not only identified the problem, you're actually trying to do something to solve the problem. And I'd like to give these last couple of minutes to you to sort of speak to our constituency, to our survivors, and give them hope that your work will catch fire and that this model, that protocol is embodying, will be what will become the norm, hopefully in the future.
Yeah. I think there's a number of great things that I'm seeing in the world right now that bring me hope in that regard. One is, as I already mentioned, the NCCN guidelines specifically calling out collaborative care, which is this model of integrated behavioral health care into the cancer care guidelines. I think means that a lot of people are hearing about collaborative care and the importance of behavioral health integration. I think more and more oncology centers are going to get pressure actually from these guidelines to be bringing it in, just similarly to how a lot of centers felt that pressure to introduce the distress screening and the depression screening. And although that moved the needle a little bit and that we're asking some questions, we've already discussed the ways in which it fell short. I think this is the next stage of that, where there will be a lot of pressure from the guidelines and from hopefully some more regulatory bodies to kind of push people toward this integrated behavioral health programming into cancer care. So I think one is that I'm seeing there's a lot more of understanding of this need and pushing it in that direction. There's also, this is on the less touchy-feely side and the more just how do things happen in the world, which is dollars. And I will say there's a lot more research coming out about the total cost of care spent for cancer patients and the impact that behavioral health can have on reducing that. And so if we think about a lot of emergency department visits and hospitalizations that are really expensive for patients and their insurance companies and things like that. And we know that things that result in high insurance costs are things that they get motivated to change and they get motivated to do something different. I think there's enough total cost of care spend that we could be positively impacting, aka reducing from the insurance side with increasing our behavioral health support. It is not that expensive when you juxtapose that with emergency department visit or an inpatient hospitalization. And if we can prevent some of that by improving our distress management, improving pain management, improving those sorts of things, will cut down on some unnecessary emergency department stays, cut down on some of those hospitalizations that we could be supporting on an outpatient basis, and really reducing that total cost of care. And like I said, the dollars are where things start to change. And if we can see that through, then that will also motivate people to increase the support at the behavioral health level on an outpatient basis. So the more we spend dollars on behavioral health, the more actually exponentially that we're going to see savings on the other side. So now that that's starting to see the light of day a little bit from insurance companies and value-based care organizations are really recognizing that, I think that's another thing that's going to push people toward offering more behavioral health support. So it becomes kind of like one of the rare situations where the business needs align with actual patient needs. So that's a good thing. And then the other thing is just not colloquially, anecdotally, that's the word I was looking for. The things that I start seeing as I'm having conversations with oncologists across the country is that everybody wants this. They just haven't figured out how to do it. And as we start sharing information around how to actually integrate care into clinics, people want to do it. And so if it becomes easier to do, it's going to start happening. And so we've started figuring out the how, and now we just need to get it in the doors.
Yeah, well done. I want to say that, of course, Angel and Rod on the technical side will flood our website and flood our organization with information about you, the work you're doing, protocol, of course, and we'll have ways of having our survivors who are listening get in touch with you or contact your organization. That goes without saying. But I guess what I would like to do is I would like to just get one last advice from you from you to us, to the caregivers that don't have the support that some of the organizations that you've adapted with and you're integrated with. The people like our nurses that have the bullets flying over their heads and they're in the foxholes and they're trying to help patients like Kelly and trying to figure out how we can keep them alive and keep them viable. You've used a lot of mechanisms and a lot of tips and pearls of wisdom. But if you were to sort of just crystallize the entire two podcasts into a few sentences, what would you recommend for us?
I think without specialized care available, I think remembering whether it's caregivers or nurses or other providers, that showing that you care by asking questions and expressing a caring response, that's the first intervention. That's the first thing that lets someone feel heard and not invisible. And that is powerful in and of itself. I would say my next most powerful intervention is deep breathing and relaxation. And to the extent that you can help someone get through the tearful moments, get through the pain, get through that panic, is some deep breathing, counting, things that kind of help you relax in the moment. Having those two things, the asking and showing you care, and then helping someone walk through some deep breathing relaxation, that's going to help tremendously with the in the moment needs of a lot of our patients.
Cara, you are truly a rock star. Angel, I would like to have you maybe tie up both of these podcasts with your very pretty spiritual bow, your analysis and your spiritual thoughts.
Well, first and foremost, I was extremely impressed, as you stated earlier, to have her on the show. I want to thank you for all of your kind words and all your experience that you brought onto this show. And I'm sure that the Croc Nation is extremely going to benefit from you being on the show. I like to come back to the one word that I found that kept hitting me, and that's integration. Because cancer doesn't just touch the body. It touches every part of a person. It reaches into your mind, your relationship, your plans, your sense of safety, and even your identity. In pediatric cancer care, they understand that families are supported. Children are surrounded by resources. Emotional care is built right into treatment, and no one asks if it's necessary. It's simple. And it simply is because that's how somehow we put all these things together. When you become an adult, that changes your expectations to be strong, to manage, to figure it out. And the quiet gap between medical treatment and emotional healing is where so many people suffer in silence. What Protocol is doing is it matters right now because they are saying that mental health is not a luxury. It's not an afterthought. It's not something you chase down when you finally have the energy. It belongs in cancer care for one day when you're waiting on scan results, when you don't know what is the next 6 months going to look like, when fear shows up at the dinner table, when hope feels fragile, that's when support matters most. So healing isn't just about surviving cancer. It's about being seen, being held, being supported throughout the hardest chapters of your life. When we care, it becomes truly integrated. Body, mind, spirit, and people just endure. They begin to heal. So today we honor every survivor, every caregiver, every family walking this road. You're not meant to carry this alone. And together with compassion, collaboration, and courage, we can say that we can put things in a better way, and that's paying it forward.
Well said, Angel. That's what a beautiful way to end. And I will just conclude by saying that we know what you're going through, and we don't want you to have a fragmented experience of your cancer journey. You may have side effects from your treatment or pain from your cancer, but that is just the superficial part of cancer. It's what's going on in your soul, in your psyche, deep in the resources of your essence. And thank God for people like Cara that are innovators and who are out there fighting for you guys to get not what you need, what you deserve. And at the end of the day, as Angel said, it's an integration of body, soul, mind, and the entire package that all of our survivors, are deserving of. So to end with our Croc blessing, on behalf of Cara, Angel, Denise, the entire board of directors, we just want to wish all of you a long, healthy, happy, cancer-free, and peaceful life. God bless you. God be with you. Peace.
Hey, Croc Nation, if today's message inspired you, please subscribe, download, and share this episode with your friends or someone who you believe needs it. Visit us at crocvip.com to connect, learn, and join the fight. Let's spread hope, one story at a time. Until next time, remember, we are not just a podcast, we are a movement.